Hello everyone, welcome back to MedSimplifiedWithN. Today we will master one of the most important joints in anatomy, the shoulder joint, also called the Glenohumeral joint. By the end of this lecture, you will know the type of joint, articular surfaces, ligaments, stability, relations, blood supply, nerve supply, clinical anatomy asked in MBBS exams. This lecture is completely based on MBBS standard anatomy, so keep your notebook ready. Let me ask you one question. Why is shoulder joint is the most mobile joint in the human body? And if it is so mobile, why is it also the joint that dislocates most commonly? If you understand this concept, half of the shoulder joint becomes easy. Let's begin. The shoulder joint is also called as the glenohumeral joint. It is synovial and more specifically, it is a ball and socket synovial joint. Remember one thing, the ball and socket joint always allow movements in multiple planes. That's why you can move your shoulder in 360 degrees. That's why the shoulder has a maximum range of the movement. Now let's discuss the articular surfaces. This joint is formed between the head of the humerus and the glenoid cavity of the scapula. Hence it is also called as the glenohumeral articulation. Hence it is now comes the most important concept. The glenoid cavity is very small and shallow, but the head of the humerus is almost 4 times larger. Imagine trying to balance a cricket ball on a plate. Will it stable? Obviously not. Exactly the same happens in the shoulder joint. Maximum mobility and minimum stability. This is the most probably the most important line of the today's lecture. Please underline in your notes also. Although it is structurally weak, our body has developed several stabilizers. One is the coracoacromial arch. This forms a secondary socket. It prevents the superior displacement of the humeral head. It prevents the displacement and then the musculo-tendinous cuff of the shoulders, that also called as rotator cuff. Remember the seats muscles, supraspinatus, infraspinatus, teres minor and subscapularis. These muscles surround the capsule and provide dynamic stability. If the rotator cuff becomes weak, shoulder instability increases. Glenoid labrum. The labrum is the fibrocartilaginous rim. It deepens the glenoid cavity. More depth means the more stability. Then the additional stabilizers are there, that are the long head of the biceps brachii, long head of the triceps brachii, negative atmospheric pressure, and then we will see the ligaments one by one. Capsule, glenohumeral ligament, coracohumeral ligament, transverse humeral ligament, glenoid labrum. Capsular ligament. It is very loose and permits free movements. It is least supported inferiorly where dislocations are common, which can damage the axillary nerve. It is most important point that if dislocation of shoulder joint is occur, axillary nerve get damaged. Medially, capsule is attached to scapula beyond the supraglenoid tubercle and margins of the labrum. Laterally, it is attached to anatomical neck of the humerus with following exceptions. These three are the exceptions. Inferiorly, attachment extends down to the surgical neck. Superiorly, it is deficient for passage of tendon of long head of biceps brachii. Anteriorly, capsule is reinforced by the supplemental bands called the superior, middle, inferior glenohumeral ligaments. Area between the superior and middle glenohumeral ligament is the point of the weakness in the capsule, that is the foramen of wide branch. This is the common site for the anterior dislocation of the humerus head. This is another favorite exam question, that is there is the weak area between superior glenohumeral ligament and the middle glenohumeral ligament. This gap is called as the foramen of wide branch. Then we will see about the coracohumeral ligament. Extends from root of the coracoid process to neck of the humerus. It gives the strength to the capsule. Then we will see the transverse humeral ligament. Bridges the bicipital groove and it holds the tendon of long head of the biceps in the plane. Next one is the glenoid labrum. It is the fibrocartilage attached around the margin of the glenoid cavity. Its job is only one, that is increase the depth of the glenoid cavity. Then glenohumeral ligament. There are three glenohumeral ligaments, that is superior, middle and inferior. Remember them from above to below. Superior, middle and inferior. Space or area between glenohumeral superior and middle ligament, that is the foramen of wide branch, common site of anterior dislocation of the humerus head. This is the diagram for the ligaments. These are the three branches of the glenohumeral ligament: superior, middle, inferior. This is the glenoid labrum. This is the coracohumeral ligament. It is the transverse humerus ligament, and this is the capsule of the shoulder joint. Let's see the bursa. There are three bursae: subacromial or subdeltoid, subscapular and infraspinatus. The subacromial bursa reduces the friction between supraspinatus tendon and coracoacromial arch. It allows smooth movements during abduction. Here is one clinical point, that inflammation causes painful arc syndrome in the shoulder joint. Here are the relations. Superiorly, coracoacromial arch, subacromial bursa, supraspinatus and deltoid. Inferiorly, long head of triceps brachii, axillary nerve, posterior circumflex humeral artery. Anteriorly, subscapularis coracobrachialis, short head of biceps brachii and deltoid. Inferiorly, axillary nerve is endangered during in the inferior dislocations. Posteriorly, infraspinatus, teres minor and deltoid. Within the joint, the tendon of the long head of biceps brachii. This is the classic viva question. Next, we will see the blood supply. Blood supply is by the anterior circumflex humeral artery, posterior circumflex humeral artery, suprascapular artery and subscapular vessels. Nerve supply is by the axillary nerve, musculocutaneous nerve and suprascapular nerve. These are three important nerves. And Hilton's law says the nerve supplying muscles acting on the joint also supplies the joint. Here the Hilton's law applied. This is the diagram for relations of the shoulder joint. These are the rotator cuff muscles: infraspinatus, subscapularis, supraspinatus and infraspinatus. Then teres, here is the teres minor muscle. This is the bursas, green colored bursas are there. Here is the glenoid cavity. It is the joint capsule. Let's see the movements of the shoulder joint. Movements can be flexion, extension, adduction, abduction, medial rotation, lateral rotation, and circumduction. These are the various movements for the shoulder joint. This is the most mobilized joint in our human body. Let's do the rapid revision. Before ending, let's revise in 1 minute. This is the type of shoulder ball and socket, articular surfaces, head of the humerus and glenoid cavity. Most important stabilizer, that is the rotator cuff muscles. Weak area, foramen of bridge, weight bridge. Most common dislocation, anterior inferior dislocation, bicipital groove ligament, transverse humerus ligament, and deepens the cavity, glenoid labrum, inside the joint, long head of biceps tendon. This diagram is here. It is the long head of biceps brachii tendon. And if this lecture has helped you understand the shoulder joint instead of just memorizing it, make it sure to like the video and share it to your MBBS friends. Comments one word shoulder done. So I know you have completed this topic. Subscribe to MedSimplifiedWithN because the next joint lecture is coming soon. Until then, keep learning, keep simplifying medicine. Thank you.